Welcome everyone, and thank you for joining us today. My name is June Ali Khan. I'm Vice President on the board and head of the Advocacy Committee. It is my privilege today to introduce Dr. Amanda Steiman. Dr. Steiman was a 2011 Geoff Carr Fellow, and since then she has been extremely busy. She is staff rheumatologist at Mount Sinai Hospital and has developed a young adults SLE clinic there, which translates pediatric patients from sick kids. She's assistant professor of medicine at the University of Toronto, director of the ACPAC program, and head of Project ECHO, a virtual learning community for primary care practitioners where she shares best practices and provides diagnostic and management support to primary care practitioners for rheumatic patients. Please welcome Dr. Steiman.
Thank you so much for the kind introduction, June. And thank you also for the opportunity to share a little bit about what I've been doing since the Geoff Carr Fellowship. I've called this Echoes and Ripples, and I hope it becomes evident why. So I'm going to start by sharing that a lot can change in a decade. And I realize it's actually now been more than a decade since I was the Geoff Carr Fellow in 2011. And I had the tremendous privilege to be the Geoff Carr Fellow under the guidance and supervision of Drs. Daphne Gladman and Murray Urowitz, and learned a great deal and developed a passion and a love for caring for patients with lupus then. And that still remains really at the core of what I do on any given day. And so thank you all for being here, for your collaboration. And I look forward to sharing a little bit more. So this first slide is really meant to introduce me a little bit. And I'll share these affiliations and some of the things that June had alluded to in the intro. Over 10 years at home, things have changed quite a lot. And so I'm sharing my family photo. Missing from the photo is our faithful Woodle, who's 2.5 years old, named Dot. But I've got a fantastic husband. It's our 16th anniversary today. And then in addition to that, Oscar is our Geoff Carr baby. So he's now 10, Rosalie is 8, and Matilda is 4. And of course, they're my heart. And I'm going to share a little bit about these other things in the slides to come. And over 10 years, other things have happened in Toronto as well, which is where I live and grew up. And so, of course, the Raptors won the pennant just before COVID. And, importantly, and all around the world, as we all well know, COVID has changed the way we live, the way we practice, and has certainly had all sorts of ramifications in the way we care for patients and in the delivery of care and access to care. And I think in many ways that, although it's been so heavy and so negative, it's really provided opportunities for us to think about the way we deliver care and whether or not we can optimize it anyway. And so perhaps if we take away that silver lining from the otherwise challenging, trying, and upsetting experience, then, we certainly can try to do that anyways. So for me, since having been a Geoff Carr Fellow, I've been engaged in clinical medicine each and every day. And I think what became so apparent to me was that there were several gaps in our ability to deliver good care to patients with complex rheumatic diseases, among which lupus really stands front and center for me. So the game changers for me. So number one, there are about 160 rheumatologists in all of Ontario. And the same was true 2 decades ago. And although the number of patients has increased, the number of rheumatologists to support the care really has not kept up in lockstep for a number of reasons, largely regulatory. We know that disparities in care delivery are amplified in rural, remote areas. And we know that there are also very significant bottlenecks prior to referral to a rheumatologist, which may reflect the lengthiest delay from symptom onset to disease management. And so we know that while there are delays, certainly, and we can't see patients as quickly as we hope, we know that even prior to that, symptoms run and ravage even prior to patients accessing primary care and mentioning these. And I think it's really amplified in the setting of complex diseases that look different in everybody, like lupus. And so these statistics are actually from rheumatoid arthritis. I can guarantee that for lupus, actually, the delay may even be quite substantially longer. And so from symptom onset to primary care is 172 days. And so if you think about that, that's about half a year. And then from primary care to rheumatology referral. And again, this is in the context of inflammatory arthritis of all kinds and not specifically lupus, which is considerably more complex in some cases. There's another delay of 115 days while there's preliminary workup and other things are being ruled out and assessed and so forth. So there are these bottlenecks in care that I think are real opportunities in some ways to address. We know that, changing gears slightly, 50% of young adults with chronic diseases are lost to follow-up in transition to adult care. And one of the things that I spend much of my time in is in transition care from pediatric lupus patients coming from sick kids across the way over to Mount Sinai Hospital where I practice. And so this rang so true and was so critical to the development of the clinic that I'll tell you a little bit more about. We also know that we globally fall short of addressing most quality metrics for chronic disease management in lupus. And so that was another improvement strategy. And so given a background in quality improvement that I've worked in since Geoff Carr, these are things that really came to the fore in terms of thinking about how I develop my practice and the academic foci that I have been pursuing. So, we look at the glass as either half full or half empty. And, there are these problems that I've just spoken to you about, but they also reflect opportunities to improve the care we deliver. And so, the question is, in a setting where we lack adequate resources to provide optimal care as it stands, how do we leverage what resources already exist to improve the quality of care we deliver? And so, locally, I'd like to speak a little bit about the Young Adult Lupus Clinic. Provincially, Project Echo Rheumatology, and nationally, the Advanced Clinician Practitioner in Arthritis Care Program. And I'll touch upon each of these briefly. So the Young Adult SLE Clinic, or YASLE, was established in 2016. I collaborate in this clinic with Dr. Earl Silverman, who's a pediatric rheumatologist and lupologist at Sick Kids. And our goals really going into this were to decrease patient attrition at a critical and formative time in their care, with that metric of 50% of patients being lost to follow-up at the transition from pediatric to adult care, top of mind. As well as to work smarter to address the quality care metrics, which are notoriously under-addressed worldwide. And these include the spheres of health maintenance and monitoring, medication adherence and discussion thereof, and barriers to optimizing adherence, as well as psychosocial determinants of health. So by way of brief overview, so the Young Adult Lupus Clinic, we first start discussing transition care at the age of 14 over at Sick Kids. And over there's an iterative process of transition readiness, transition planning, and then meeting the patients who are coming over to the adult side. And from the ages of 18 to 22, there's a collaborative care model that we've developed where Dr. Silverman and myself and the fellows in the clinic see patients collaboratively. I learn about the patients and get to know them in the context of someone who's known them so well through their disease management. And so that provides a lot of comfort, a lot of security, and a lot of continuity, both from the clinical side, but also for patients who have this familiarity and the familiar face in the room as they transition over to the next phase in their care. And we know that that's been a deterrent in large part in the literature for why patients do get lost to follow-up between pediatric and adult care. And so we felt that this model would serve to try to offset that tendency. Once the patients have been in our clinic for 4 to 5 years, they then transition over to my own adult clinic, wherein I care for them going forward. And so we thought it was a good idea. We wanted to know it was a good idea. And so we do have data to share. And this is actually being presented at the American College of Rheumatology meeting next month. And so of 132 young adult patients who transitioned from sick kids over the first 5 years of the clinic, we found that 98.5%, so only 2 didn't have the transition clinic visit to first visit at Mount Sinai Hospital. 93%, as opposed to that international metric of 50%, were seen within the first, within 1 year of the date of transition. And 99% of patients continued to be seen a year after transition to adult care. And while I don't have this statistic on this slide, the metric has remained consistent for years after and into adult care. And so we feel like this was proof positive that this model is a supportive one that has been working well in that context. And so that was a really exciting finding. We also worked iteratively to develop a template that we use in each and every clinical encounter. And that's to assist in addressing all of the various aspects of quality care consistently. And so there's a lot that transpires in a visit. And you know that depending on disease activity, depending on the things that are most top of mind, you tend to address some things, but perhaps not all things. And I think that that's the challenge that we are met with in complex care. And so we wanted to make sure that we were addressing these things consistently and in adherence with what is thought to be ideal care in the literature. And so we looked at these metrics, and these are just a few of the 20 or more that we addressed with this template. We learned that discussion surrounding medication adherence at every visit rose from 36% pre-template to 97% once it was implemented, and that's remained consistent. This isn't a spot measurement when we first implemented it. This has remained consistent over years now. Discussion around mood and mental health increased from 20% of visits to 90% of visits. Discussion of sexual health increased from 11% to 91%. And with this came discussion of contraceptive management, which is really important in the context of patients who are perhaps at varying levels of disease activity or on medications that can be teratogenic or harmful to a fetus. And that increased from 4% to 75% of all visits. And so we feel that this template's been a really important and fairly simple intervention that's allowed for us to care better. And so we've been really excited to share this. And I thought that would be particularly germane to the group who's present today. At a provincial level, I've been co-chair of Project Echo Rheumatology. We know that there's a burgeoning need for rheumatologic care. Wait time benchmarks are not frequently met. And for systemic inflammatory rheumatic diseases, most delays occur, as mentioned, prior to referral to the rheumatologist. And so that was the problem. So there's a shortage of rheumatologists, yes, perhaps, but is there also a shortage of rheumatologic acumen in the system, right? So can we demonopolize rheumatologic knowledge in order to better collaborate with our primary care colleagues, with other specialists involved in rheumatic disease management? And so can we work better or smarter by leveraging resources that already exist rather than introducing further stressors into the system? And so that's really the spirit in which Project Echo rings true, I think, in rheumatology. And so the extension for community healthcare outcomes is the ECHO model. It was first developed in New Mexico in the context of hepatitis C, which was endemic, and only 2 hepatologists across the entire state. And we use technology to leverage scarce resources. We share best practices and reduce disparities. And we apply case-based learning to manage complexity between primary care and a rheumatologic hub with a multidisciplinary team of experts. And then we evaluate and monitor outcomes. And so this is really the model for Project Echo. We were Zooming before Zoom was a thing. So we started back in 2016, pre-pandemic. We have weekly interactive video conferencing sessions that connect primary care and specialist teams. This is not unique to rheumatology, but rheumatology has benefited from this model. Sessions include both didactic presentations that are brief and very clinically pragmatic, as well as case-based learning. And really the spirit is that we all teach and we all learn. So we learn from primary care learns from us. And in doing so, we build a community of practice and we are able to collaborate in care across the province. So most who attend our weekly sessions, and at our last session yesterday, we had 50 people in attendance, which is quite common. And we've had people who have stayed on for years, who are lifers, and others who come and go. And so there's this flexibility in this model where they log on, they learn, they share cases. And it's actually quite a lovely way to learn. So we have a didactic, we focus on pragmatic approaches, and then presentation by a core hub. And I'm just going to share, this is a family doc in Massey who's been with us for a couple of years. And I'm just going to share a few seconds of a discussion that was on Zoom with his permission and with full confidentiality of patients in mind here. And so that's all been adhered to.
Anyway, that was one observation. Otherwise, did you x-ray his hands? He's got marked autodeviation of the MCP joints, right? At the MCP joints. So it'd be really interesting to know if his x-rays of the hand showed any erosions and what the radiologist said about them.
I didn't do them recently because he wasn't actually complaining of any hand symptoms. It was just the wrist, the last.
Anyway, that was one observation.
And so that just gives you a flavor of this collaborative model wherein two family docs are discussing complex rheumatologic cases in quite a bit of detail with the support of the Rheumatologic Hub, and are then their local champions for delivery of rheumatic disease care that then collaborate closely with rheumatologists and have this community of practice in hand. So it's been very exhilarating, it's been very gratifying, and I think it's been a wonderful collaborative educational opportunity. We've had 450 primary care providers go through ECHO to date. All LINs have been represented, so this really has reached province-wide with significant increase in primary care provider self-efficacy and knowledge surrounding rheumatic disease and their management. So there's that measurement piece. And so we're working on various metrics to capture adult learning in this complex field. So that's been a very worthwhile challenge. And finally, the ACPAC program, which is a hybrid academic and clinical training program that prepares select and experienced physical therapists, occupational therapists in large part, as well as a few nurses, chiropractors for extended practice roles in the diagnosis and management of patients with arthritis and musculoskeletal disease. And the focus is on assessment, on diagnosis, on triage, and independent management or co-management with rheumatology of complex rheumatic diseases. And so ACPAC, there are now over 100 graduates stationed across the country, as well as a few internationally. This is a rigorous year-long program. There are clinical practica, there are exams at the beginning and at the end, and they've been integrated into rheumatic disease clinics, into primary care, and into collaborative care models through COVID. And so they've been a real boon to the way we deliver care and really part of the fabric of rheumatic disease care in Canada. And so it's been very exciting to be a medical director and to have taken the baton that was passed by Rachel Shupak and Katie London, who had developed this program 15 years ago, a few years back now. So, ultimately, and this is a busy slide, but the idea is that there's so many different opportunities to collaborate with primary care, collaborate amongst ourselves, and to really think about how we use the resources we already have to deliver care better and to support patient care better. And, that's how I spend my time. That's something that's near and dear to my heart each and every day. And I feel tremendous privilege to be able to care for these incredible patients, to care for lupus patients, and I want to thank you for the opportunity to share these with you. And so thanks very much, and I am happy to answer any questions that you may have.
Thank you so much, Dr. Steiman. If anyone has questions, you can put them into the chat and we can get to them.
It looks like,
Oh,
here we go. We have one here. How many ACPACs are practicing in Ontario?
So by far and away, most of the ACPACs are located in Ontario. And so I believe the most recent number was in the realms of 80 to 90 who have stayed within the province in various capacities. And so it's been interesting to see how, with the unique skill set and expertise that they've had, they've been able to really integrate into multiple models. And really the sky's the limit. So our most recent graduates have put forth proposals in the local networks that they work in and have really been able to leverage their skills. And so ACPACs in the many dozens across the province in various capacities.
Thank you. I've actually got one myself for you. And that is for YASLE. How many of your patients continue at Mount Sinai, and at what point in time, I guess, do they transition to other clinics?
So virtually all of them who have graduated are either about to be seen, and this is a fairly nascent clinic, so we have 4 to 5 years of care. We started in late 2016, and so we have a few graduates who have moved beyond the 22-year mark when we stop seeing them in the young adult clinic and they become full-fledged adults. They all stay with me. So there have been 2 who have moved out of province for university, for work prospects. And of course, they've been transitioned away to rheumatologists more locally. But the remainder of them, the model is really for them to stay and have that continuity of care. And that's always been the plan.
That's great. And have there been any mentorship programs set up for linking patients themselves?
So it's a great question, Andrea. So mentorship programs, by way of, just to clarify, so with respect to patient support and so forth.
So let me find her, and I can unmute her so maybe she can clarify herself.
Oh, hi there. Hi, Dr. Steiman. Thank you so much. Mentorship in linking patients, almost like a big sister or big brother program where patients who have gone through the Sick Kids process and are now in an adult facility, just to help new patients or newly transitioned patients in the adult facilities share their experiences, personal contact with that personal experience, drawing on that for the link or mentorship.
So it's a great question. We don't have anything formally set up. I think that's it's a wonderful potential prospect, and offline, if there was something that you wanted to discuss, I would be delighted to explore that. There are some challenges associated with that from the perspective of confidentiality and so forth that could be overcome, but certainly worthwhile considering. And so thank you for bringing that forward. And I would invite that discussion.
All right, we have another question from Dr. Eltal. She says, thank you for the great talk. It has been great collaborating on projects together. Can you describe the biggest challenge for transitioning from an adult rheumatologist perspective? Sorry, stumbled there.
I want to, and I could only see who was in the audience once I got rid of my slides. And so I want to, first of all, acknowledge Dr. Eltal, who's been a wonderful fellow in the YASLE clinic, so she really shaped the way we saw patients for the couple of years that she was with us, actually. And so we miss you, Tella. And it's a great question. I think the biggest challenge from an adult rheumatologist standpoint is really navigating that fine line of progressive divesting of parental involvement, and with patients taking progressive ownership over their own care. I think that there's a lot of eagerness, there's a lot of receptiveness among many patients. For some, it's quite terrifying. And I think for parents, who have had children with very significant illness, I think that's really the most challenging of relationships to manage in some ways, and I think a really important one. It's really at the core of what we do and how we navigate early care in adult care. So I think being sensitive and delivering tailored and individualized care on the basis of need for every individual in that respect, in addition to all of the clinical care that we deliver, I think it's been challenging and worthwhile.
I think that wraps up the questions. I don't see any more. So I would like to thank Dr. Steiman very much for sharing her obvious passion on educating the entire world on lupus, as well as sharing her passion with respect to lupus patients. Great presentation. Thank you for being with us.
Thanks so much for the opportunity.
All right, bye-bye, everyone.